Welcome to the new season of MesoTV. MesoTV is a program of the Mesothelioma Applied Research Foundation and is made possible thanks to the generous support of our sponsors. To learn more about our sponsors, please watch the following message.
My name is Kelly Batley.
My name is Clay Thompson.
My name is Neil Mowney.
We are MRHFM, a national firm with 70 attorneys and 11 offices across the U.S.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
Hi, my name's Joe Bellick, and I'm the founding partner of the law offices of Bellick & Fox. We support the mesothelioma community by providing first-quality legal representation to mesothelioma patients and their families. During these troubling times, we're proud to support the Mesothelioma Applied Research Foundation so they can continue the work that they do every day on behalf of mesothelioma patients and their families.
Hi, Dr. Mansfield. Thanks for being on this MesoTV with me. I'll just have you introduce yourself real fast. I know you've been on other episodes as well, but just give us a little background of yourself and where you're at.
Yeah, thank you for having me back. I'm Aaron Mansfield. I'm a medical oncologist at Mayo Clinic in Rochester, Minnesota.
Thank you. And we're here today. We're going to talk about a peritoneal clinical trial that you're heading up. And I kind of wanted to start with why this is so important and a little bit about peritoneal mesothelioma because it is so rare and there are limited trials out there about it.
Yeah, this trial's been a labor of love. It's been in development for about 4 years between the cooperative group and the National Cancer Institute, and it just recently has been activated, received central IRB approval. So the purpose of having this is we have so little prospective data available for peritoneal mesothelioma. So much of what we do for the disease is extrapolated from what we do for pleural mesothelioma, single institution case series, and we have very little prospective or randomized data. A number of trials for pleural mesothelioma don't include patients with peritoneal mesothelioma. Some of them do, some of those have been negative, so they haven't changed practice per se, and we often don't get a great subgroup analysis. So anyways, the point is, I see these patients, I try to figure out what to do with them, and I feel like there's this wide open field and I don't know where the signposts are. So this was, again, an effort of 4 years to try to bring some evidence to what the best management is for these patients. And being a medical oncologist, that perspective is for what's the best with systemic therapy. Yeah, what should we be offering to them?
And right now, in the peritoneal space, there is not really a standard of care, correct?
Well, again, we extrapolate from pleural mesothelioma, and we also work with our colleagues in surgery. So we rely on their surgical opinion to help us determine, can this patient go to surgery or not? And then if not, then we're reliant upon what we do for pleural mesothelioma to guide what we recommend. Sometimes our surgeons will say, well, we might be able to operate, but can you shrink this down a little bit? And then we have to decide between chemotherapy or the newly approved immunotherapy for pleural mesothelioma to help make that assessment.
Perfect. As far as the trial goes, it's a phase 2 randomized trial. Can you just talk a little bit about what phase 2 means?
Yeah, so I may answer that by starting with phase 1.
Yes.
Most phase 1 trials have a goal of establishing the safety of a drug or a combination or the safety of a certain regimen within a disease. So we know patients with peritoneal mesothelioma get platinum-based therapy and have had immunotherapy and have tolerated it. So we don't think we need to do that basic type of phase 1 study. So phase 2 studies, they come in different flavors, but the goal of those is to really get a sense of whether treatment is effective or not. Some of them are randomized, others are not. Even though this one is randomized, all patients get therapy.
Okay.
Most people would argue that a platinum-based therapy is the standard of care for peritoneal mesothelioma, and that is offered to everyone. Now, half the patients will also get immunotherapy with that chemotherapy. And what we're trying to do is see whether or not that improves responses to our treatments. So that's the key here. We're adding one thing to what the standard is and seeing if there's a difference in responses between those who do and don't get that additional immunotherapy on top of the standard.
Wonderful. And the other really good thing to point out with this study is that you can be surgical or non-surgical, correct?
Exactly. This variant of mesothelioma, I'm sure to viewers of the foundation, it may seem common, but this is actually a rare variant of a rare disease. And with that being said, we try to design the trial to incorporate anyone, be it surgical or not. We just wanted to try to, again, maximize who could go on to the study, whether or not they're surgical candidates.
Wonderful. And I wanted to break down the arms a little bit of the actual trial for any patients that may be watching this and may be thinking about entering the trial. So I was going to start with, it's actually arm 2, which is the arm that has the chemotherapy in it, but no immunotherapy. And within that, there is a surgical and a non-surgical. And they get a platinum-based, a Alimta, and then also a Avastin, correct?
Correct.
Okay, and they get 4 cycles of that.
Correct.
And then after the 4 cycles, if you could explain kind of what happens between the difference if you're surgical or non-surgical.
Yep. So so that backbone we think would be an accepted standard to give. It's been in the guidelines for pleural disease. The MAPS trial conducted in France helped create this regimen. So yep, patients would get these 4 cycles. We would get imaging to see their response. And if they are surgical candidates, they could then go to surgery. Once they recover from surgery, they would be observed with imaging to look for recurrence and other things that way. If they are not surgical candidates, they can then proceed with maintenance therapy. And for this arm, it's a little unique where the treating physician can either give maintenance bevacizumab, very similar to the original clinical trial that showed benefit to this regimen. We would drop the carboplatin and pemetrexed, and they could give bevacizumab, the anti-VEGF drug, or they could switch to the immunotherapy because that had not been given. So that's really at the discretion of the treating physician. Because if there is a response, with the 3 drugs without the immunotherapy, you might be able to maintain that with the bevacizumab and switch to an immunotherapy later. If not, then that immunotherapy would be an option. So this way, there's still treatment options for patients to consider, even if they're not surgical candidates.
Perfect. And then the experimental arm, they get 4 cycles up front of the platinum, the Alimta, the bevacizumab, and then the added immunotherapy.
Correct.
Could you tell us a little bit about how those break down if you're surgical or non-surgical?
Yeah, very similarly, after those 4 cycles, we get the imaging and the surgeons would decide can they operate or not. I'm not allowed to play a sharp object, so I don't get to make that determination. The surgeons get to. But if they do make the determination that the patient can go to surgery, they would do so. And then similar to the other arm, after that point, these patients would be observed. They will have already been treated with chemotherapy and immunotherapy. They may even receive HIPEC at the completion of the surgery. And then we would let them recover from surgery and enter an observation phase where we're doing imaging-based monitoring and physical examinations. For the patients who are not surgical candidates based on the extent of disease or the subtype of disease, they could then proceed with maintenance therapy with immunotherapy and bevacizumab.
So they'll get both of those if they're non-surgical in the after the 4 cycles.
As long as there's not been toxicity with one. So if there is toxicity, the investigator may hold one of those drugs. So I just don't want to say everyone
Sure.
gets it, but that there's a possibility of that.
Yep. Okay, perfect. And I know we had just talked about this, but as far as the surgical aspect goes, who does perform the surgeries for these patients?
Yep. So there are a handful of surgeons who specialize in the resection of peritoneal mesothelioma. They're primarily at the larger academic centers. For this trial, most patients would be expected to get the chemotherapy and the surgery at the same site. The medical oncologist would be giving the systemic therapy, and then the surgeons that partner with those oncologists would then be operating.
Wonderful. And then I wanted to talk a little bit about the primary outcome of the study. What are you guys looking for as far as the study goes?
Yeah, so there's a few things to consider here. Because we're allowing patients who are and are not surgical candidates, that's rather unique to this study. It's been something we've debated a lot within the cooperative group and at the National Cancer Institute's CTAP. Because of that, we have to use response rate as our primary endpoint. So we're really looking at does this regimen improve how many patients have tumors that shrink a certain amount or more by getting this regimen. So we can't, because we're incorporating different groups, and on average, patients who are able to go to surgery typically do better. Looking at progression-free survival or overall survival are not the primary endpoints in this study. We're really getting a sense at, do we get better responses than by adding immunotherapy than by not adding it?
Okay, perfect. And inclusion criteria, I wanted to touch a little bit on some of the bigger ones that are in there. So no prior treatment is one of those. Can you talk a little bit about that?
Yeah, so we're trying to capture patients who are newly diagnosed with this disease. It's a little tough to take patients second or third line or after surgery. They may have already received chemotherapy or immunotherapy. So since there's so little evidence out there for what to do here, we've taken what we believe is an accepted frontline regimen and have added immuno to it. So we're really trying to get a sense of whether they work, and if someone's already had one or both of those drugs, we really won't be able to assess that. There may be resistance to one of the drugs we're administering.
Okay, and then also performance status. I did notice that that was something that they wanted to be somewhere between 0 and 1. Can you just kind of say what 0 to 1 is for any patients that may be wondering?
Yeah, so a performance status of 0 pretty much means that your cancer, you may not have known it unless we incidentally discovered it and we told you it was there. For someone with a performance status of 1, there may be some limitations to your normal activities. Maybe there's some pain or change in appetite or things that way, but it may not limit your function that much. 3 and 4 are some of the higher numbers, but those are for patients who aren't getting out of bed much at all because the cancer has really limited their activities. So most clinical trials require that patients be more functional and not severely debilitated by their disease.
And then I also did see that no active history of autoimmune disease or immunodeficiency as well. I also didn't know if you wanted to touch on any of the other inclusion criteria, just so that patients are aware.
Yeah, so the autoimmunity is really important. There are some rare exceptions, but because this trial does involve an immunotherapy, when someone has an autoimmune condition, the immunotherapy has a chance to significantly worsen it. So most trials with immunotherapy do not allow patients with severe autoimmune or some degree of autoimmunity to come onto them. Now we're still trying to tease out which autoimmune conditions wouldn't preclude the use of immunotherapy, but this trial is sort of in line with the other ones out there right now, where those patients are unfortunately excluded from participation.
And I wanted to also get your insight a little bit on the actual immunotherapy that you're using. I know that patients are going to wonder a little bit about the side effect profile of it, and also kind of how it works. It is a PD-L1 as well. If you could just sort of update us a little bit on what that means, and why this immunotherapy was chosen.
Yeah, so we are using atezolizumab. It is a generic name. The brand name is Tecentriq. This is made by Genentech. It's a PD-L1 inhibitor. It's been FDA approved for other indications like small cell lung cancer and non-small cell lung cancer, where we've seen it has activity in other malignancies. So we know it's an active drug. It binds to PD-L1, as you mentioned. The other end is PD-1. So drugs like pembrolizumab and nivolumab bind to PD-1. So, but PD-1 and PD-L1, when they bind, it inhibits the T cells from functioning. So we are trying to disrupt that. And you could either disrupt it by making an antibody that targets PD-L1 on the tumor cells, or PD-1 on the lymphocytes, the T cells. So I'm really agnostic as to which end we target. We see it works in other malignancies to target either of them. There may be some nuances in terms of adverse events and whatnot, but I do think we've seen lots of efficacy across multiple tumor types with either approach. So I'm thrilled that we have a pharmaceutical company sponsoring the trial and providing the drug. I'd honestly be okay if this were a PD-1 inhibitor instead of a PD-L1 inhibitor, but at the same time, we have seen success in pleural mesothelioma with some of these drugs, not FDA approved, but just we do know there can be activity with the PD-L1 inhibitor. So everyone has to get the same one for the purpose of the trial. I'm not certain there's a clear differentiator yet that PD-1 or PD-L1 inhibition would be superior. I think they both can work.
And both of those on the immunotherapy side, they both cause your immune system to be at a heightened state. I mean, the goal is that your own immune system is going to then recognize the cancer cells and hopefully attack them. And I know in kind of terms that are easy for patients to remember, as a nurse, we used to always say for side effects or adverse events, it's the itises or the isms. And so can you talk a little bit about just sort of the adverse event profile of that, of Tecentriq?
Yeah, as you said, these drugs can heighten the immune system. You hear different metaphors. I think that these drugs disinhibit the immune system, so to speak, because what we believe that their function has been inhibited by the tumor. Some people say it's like cutting the brake line to a car, so it then starts moving. So
I was just going to say, no brake pedal then, yes.
Yeah, so you've cut the brake line and you can pump that pedal, but it won't stop. So with that in mind, the immune system's pretty smart, but when we give a drug like this, we can't always hone the response only to the tumor and not other parts of the body. So sometimes the immune cells that we've cut the brake line for are disinhibited or heightened. They can then attack the skin and the thyroid. Those are two of the more common side effects we see with these drugs. So those are common and usually not that severe to deal with some exceptions. But the less common side effects can be more severe, and those are the ones that keep us up at night. And when the immune system attacks the lungs and causes a pneumonitis, these itises you're saying, so when there's an itis in the lungs or the gut, we're dealing with people who might end up in the intensive care unit and need to be intubated to help breathe, or patients who have severe diarrhea because the colon is inflamed, or if the liver is attacked, the enzymes we measure in the blood skyrocket, and we have to hold therapy and possibly give steroids or other drugs to try to counter those effects we're seeing. So yeah, you said the itises, inflammation pretty much from head to toe. We've pretty much seen any itis that has been reported, we've seen it with these drugs.
And the big thing is for these patients to know is that reporting any sort of difference in status is very important to your healthcare professionals, because the earlier that we catch these itises or isms makes a huge difference on whether or not they can actually stay on drug.
Yeah, absolutely. I would counsel patients, don't wait till your next visit if you're more short of breath, if you're having bad diarrhea. Your team needs to know this so they can see you and help you out. Waiting 2 weeks, if that's how much later your appointment is not a good strategy.
Yes, we used to often see patients that tried to power through, but with the immunotherapies, you don't want to power through. You want to get
completely.
help. Yes.
Completely. Yeah.
Wonderful. Well, is there anything else that you want to tell us about this trial? It's very exciting, especially in this space that we just don't have a lot of data on. Is there a certain amount of patients that you're trying to recruit, or are we just seeing where this goes? I know, with the coronavirus and all of that, we've had a lower recruitment status, but hopefully things will be picking back up.
Yeah, I think the pandemic's really affected clinical trial activation, accruals, but even though the pandemic is a huge concern and we're trying to work around that, we still need to think about our patients with mesothelioma and other cancers and move the needle forward to figure out the best treatments for them. So this trial, it just opened, so our site and others are starting to activate it. So as of today of the recording, it's not available this second, but at the Mayo Clinic system, it will be soon, and other sites are coming on board too. So the hope is end of 2021 or early January, we start seeing the trial be made available to patients around the country. The goal is to accrue just over 60 patients, and that would mean about 30 in each of the arms. When we have trials open, there's analyses to make sure they're meeting accrual goals, and if not, trials may get shut down. But it's a rare variant of a rare disease. It took a long time to develop and bring to this stage. So the hope is we can accrue to this in just a 2 to 3 year period and provide the community with data to see if this is an approach we should be offering our patients. So.
Great. Thank you so much for joining me today. I really appreciate that you came on today for us to tell us about this, and hopefully we can get this trial up and running and get some patients into it.
Yeah, thank you for the time. I really appreciate it.
Thank you.